everyone. I'm Dr. Laura Pace, and I'm absolutely delighted to be joining you today to talk about dysautonomia and the neuroimmune axis. And we're going to focus on diagnosis and management. Here are my disclosures. And then here's a slide that includes abbreviations that may be important throughout the lecture. Well, in my opinion, the neuroimmune axis represents the next frontier of scientific discovery in clinical medicine. And really, given the complexity of conditions that are arising from dysfunction of the neuroimmune axis, the time is now for precision medicine. And so up until very recently, we had thought that only neurons use neurotransmitters and only immune cells use cytokines and chemokines. But we now know that cells of the nervous, immune, and endocrine systems can all use neurotransmitters, cytokines, and prostaglandins to communicate with each other using shared receptors. And what does this mean? This means that the autonomic nervous system can control the behavior of immune cells. And immune cells can signal directly to neurons, influencing their activity as well. And so what does this mean for patients with neuroimmune axis disorders such as PoTS? It means it's complicated. And when we're thinking about these conditions clinically, about how to diagnose them and how to appropriately treat them, we have to be keeping this new information in mind. So before we get started, I'm going to go through some basics of neuroanatomy of the autonomic nervous system. And so I know I don't have to tell this audience, but something I tell my patients who are kind of new to thinking about autonomic nervous system disorders is that the autonomic nervous system controls everything you don't think about until something goes wrong, and it's literally all you can think about. This also includes the immune system. Also, communication within the system is not simple. You have sensory and effector neurons that are influenced by the local environment. And the reason I'm pointing this out is these are tissue-based processes. This is particularly important in large organs like the gastrointestinal tract and the skin. The other point is that blood is often not a good proxy for the processes that are happening within the tissue. So if you've ever been told by one of your physicians, well, all your tests are normal, so there's nothing wrong with you, the better thing they should have told you is, we haven't run the right tests to figure this out. And so one of the things I'm going to talk about today is how can we improve diagnostics in this space by doing a better job at tissue-based diagnostics. The other thing is that communication within these systems is not simple. It's bidirectional, and it includes components of the nervous system, immune system, and endocrine system. The other point that I want to make, and the reason I included the schematic on the left-hand side of the slide, is that I think when we think about autonomic nervous system innervation of the gastrointestinal tract, we disproportionately talk about the vagus nerve, and that's shown here in blue. And we don't talk as much about the sympathetic innervation of the gastrointestinal tract, which is running through celiac, mesenteric, and pelvic ganglia, and is innervating all the components of the gastrointestinal tract, including the esophagus, stomach, small intestine, colon, rectum, pelvic floor, other organs that are included in the pelvis, like bladder and sexual organs. And so when we're just so focused on modulating the vagus nerve, we're missing opportunities to modulate the sympathetic component of the autonomic nervous system and its impact on the gastrointestinal system. The other thing is that when we're talking about sensory, so these afferent signals, they're translating tissue-based environmental cues back and integrating those cues to respond using efferent signals. And so these are really complex processes. Some of them occur by local reflexes, but others are actually going through the peripheral autonomic nervous system, central autonomic nervous system, the broader central nervous system, and then responding back at the tissue level. If we look at the anatomy of the gastrointestinal tract in cross-section, so this is a cross-section through the small intestine, what we can see is this is an incredibly complex organism. But what I want to draw your attention to is this is called the lumen. So this is the inside of the gastrointestinal tract. So if I was to do endoscopy, this is the area of the gastrointestinal tract I'm looking at. And this is really the outside world. And so if we ingest food or water or medicines, this is where they're ending up, in the lumen of the gastrointestinal tract. There are also a lot of microbes there. And so what the gastrointestinal system has to do is it has to regulate absorption of macromolecules, vitamins, medicines, and water across this membrane while keeping the outside environmental components, such as the microbes that are present, well within the lumen. This is a complex process with lots of opportunities to go wrong. The other point that I want to make is that when I do endoscopy and I take routine biopsies from the gastrointestinal tract, I am only able to sample that epithelial barrier layer and a little bit of tissue underneath. What I'm not able to look at is the submucosal plexus or myenteric plexus, which are components of the intrinsic autonomic nervous system within the gastrointestinal tract. You'll also notice that the gastrointestinal tract is heavily vascularized. There's lymphatics and lots of other nerve fibers, which include components of that intrinsic autonomic nervous system and extrinsic autonomic nervous system. It's also comprised of a lot of extracellular matrix tissue. The function of the gastrointestinal tract really is for nutrient and water absorption, but its functions along its length change. So the stomach is primarily for food bolus processing. It doesn't really absorb much. The small intestine really is the primary kind of workhorse of the gastrointestinal tract. This is where further macromolecular breakdown occurs, nutrient absorption occurs, water absorption occurs, but also, really importantly, immune system training and neuroimmune axis communication is happening here as well. The colon really is an organ that we could live without very easily. It primarily functions to absorb a little bit more water, store waste, and form stool. And so we can easily live without it, even though it causes a lot of symptomatology when something goes wrong with it. The last point I want to make is that the gastrointestinal tract is the largest interface of the nervous, immune, and endocrine systems. And the reason I'm saying that is that because if you have disruption in any of these systems, it's going to impact your gastrointestinal tract function. It also means when I'm trying to treat symptoms related to these other conditions, I have to know what I'm treating because it's going to allow me to select better interventions that won't just mask symptoms, but will truly treat the underlying physiology. And so I'm also including this slide where we talk about extracellular matrix interactions with the neuroimmune system. And so the extracellular matrix is really the foundation or structural architecture of all tissues. Sometimes we incorrectly refer to this as connective tissue, but really it's more appropriately named the extracellular matrix. And we should really be thinking about this in the context of extracellular matrix disorders such as hypermobile Ehlers-Danlos syndrome or the hypermobility spectrum disorders. Because the extracellular matrix is modulating immune cell functions, including migration and signaling, immune cells are also modulating the extracellular matrix structure and integrity. And by this, I mean that they're regulating barrier function, neuroimmune communication, and also having an impact on these extracellular matrix disorders. This also means that the central nervous system, peripheral nervous system, and autonomic nervous system are modulating the extracellular matrix. And they're doing this in a couple of different ways. Some are by directly interacting with cells that form the extracellular matrix, and others are by directly interacting with immune cells that can break down the extracellular matrix. And in turn, the immune system is modulating the extracellular matrix as well. And so if we just sort of summarize this really complex idea of the neuroimmune axis, we have components that sense the environment. And so when we're talking about this, this is tissue-based environmental signals that are being integrated and acted upon by the central nervous system. You're having central memory of some of these, and I won't go into detail, but they've now proven that if you have an adverse reaction and an immune response to certain stimuli, your brain can actually store that information. And when you, excuse me, think about that prior exposure, maybe see it, smell something related to that, your brain can actually recapitulate that immune response even without the stimuli actually being present. So it's getting really, really complex. We also have neuronal control of immune responses, and again, immune regulation and modulation of neuronal activity as well. And again, we have a common language among all of these systems. And so what does this mean? It means the neuroimmune axis is playing a critical role in coordinating communication between these various body systems to maintain homeostasis and respond to environmental cues. And our current testing may not be adequate to pick up this complexity. So in summary, we have this critical role in coordinating communication and responding to environmental cues. We now know that the gastrointestinal tract is the largest interface of this nervous, immune, and endocrine systems. So again, we cannot think about them in isolation. We have to think about them as related processes. We also know that the nervous, immune, and endocrine systems are using this common language to interact with each other. And so we have to think about that when we're running tests and selecting medications to treat these conditions. And while I won't talk about it in detail, the microbes that reside within our gastrointestinal tract are also communicating with the host through this neuroimmune axis. And so if we look at this schematic where we have peripheral neuroimmune interactions within the gastrointestinal tract, you start to appreciate that you have nerve fibers within the gastrointestinal tract wall that are directly innervating and interacting with resident immune cells. And so this means that as you have changes in that local environment, either because of infection as shown over here, just the presence of microbes, another type of infection, you're going to have very different immune responses, and you're also going to have very different neurological responses to this as well. And so I'll just give you an example. And so this is an example. So this is an enteric neuron here within the tissue. So this is intrinsic autonomic nervous system nerve fiber. It is releasing a factor that leads to the health of these resident muscularis macrophages. And macrophages are required to release factors that kind of feed back and control motility via these intrinsic autonomic nerve fibers. And so you kind of have this really codependent mechanism for the enteric neurons are necessary for macrophage survival, and then macrophages are necessary for appropriate motility. So you can quickly see if you have dysregulation within the autonomic nervous system or a decrease in the number of muscularis macrophages, you can end up with a gastrointestinal motility disorder. So let's look at what happens during an infection. So now you have extrinsic sympathetic nerve fibers that release norepinephrine that's recognized by the muscularis macrophages. And what the muscularis macrophages do is they're releasing these protective polyamines that will protect the enteric neuron from being damaged by an inflammasome-mediated cell death in response to infection. And so if you have, again, any disruption in either extrinsic signaling or macrophage signaling, you have it can lead to a feed-forward cycle of muscularis macrophage depletion, enteric neuron cell death, and dysmotility. And so this is going to be a condition that's much more difficult to manage rather than just treating symptoms. Now I'm going to have to do something that can maybe help us re-innervate those components of the gastrointestinal tract. So now I'm going to just give you a couple of examples about the neuroimmune axis kind of in action and learning and memory and how this can impact some of the symptoms that some of you may have. So this is the immune system and inflammation in the setting of gastrointestinal pain after infection. So let me sort of take you through. So panel A on the left-hand side of the slide is during an acute infection. So you're kind of going throughout life and you're totally fine, and then you get an infection. And here, this is a Citrobacter-mediated infection, but it really doesn't matter. It could be bacterial or viral. It doesn't matter. The same processes actually are triggered. What happens is you have a disruption in that epithelial barrier that's keeping the outside environment out. And so you have crossing of the barrier of microbes and food particles that come with it. What happens is you stimulate some of your mast cells, they degranulate, they release histamine, they're trying to help clear this infection. And then what can happen is that you clear the infection, the epithelial barrier goes back to normal. You now have microbes where they belong, which is in the lumen of the gastrointestinal tract. You've cleared the Citrobacter that was the pathogenic trigger for this. But in the meantime, what has happened is these mast cells that were not sitting that close to your sensory nerve fibers in your gastrointestinal tract wall have now moved closer to these sensory fibers. And they're also now coated. This just shows one IgE molecule, but there can be coated in these IgE molecules that recognize this food antigen that came across when you had the infection. And so you're going along just fine. You're excited because you cleared this infection. But lo and behold, the next time you eat the food that this mast cell has decided to recognize, the mast cell now sitting closer to this nerve fiber becomes activated, degranulates, activates the sensory nerve fiber, and now you have abdominal pain. And now you have abdominal pain in response to a food you've always been able to tolerate. So this is how infection is leading to this sensitization of the neuroimmune axis within the gastrointestinal tract and causing significant symptomatology. The important point to remember here is that on blood tests measuring IgE molecules, this will not be picked up because this is a tissue-restricted immune reaction. But this is a food allergy. This is just another example. Again, essentially the same process now shown in panel A. Here you have food allergen coming across. This could be in the setting of infection or some other process, but you get sensitization of the dendritic cells that signal to your T helper cells. You get release of cytokines, activate B cells that eventually produce IgE molecules to said food antigen. And then you have a mast cell with these high affinity IgE receptors that bind this IgE in the tissue. And so then the next time that these mast cells are just sitting around in the tissue, but now they have this IgE receptor on them, next time they're exposed to the allergen, they become activated. They release a signaling molecule, as does the epithelial cells. This signals to the brain that we should avoid this food. And so what's really important to remember is this leads to avoidance of food allergen. So this is essentially a learned response. This is learning and memory. This is a protective response that you've had a bad reaction to this food in the past, and so now you're going to avoid it. And so we have to be careful when we're thinking about people who have been diagnosed, I think, incorrectly with food-restricted eating behaviors, because even though they're not having a local reaction, their brain is remembering and they're saying, nope, I don't want this food. And so we really do have to believe our patients when they're telling us, I can't eat that anymore, because this is a centrally coded process that is being driven by the neuroimmune axis. And again, this is an evolutionarily protective mechanism. So for complex conditions, I hope I've convinced you that we need a systems biology approach when thinking about them. And so when I think about neuroimmune axis disorders, I think about conditions like autonomic disorders, dysautonomia, or POTS, and I kind of put them all right here. But there's a lot of other conditions that our patients have. Some of them have mast cell activation syndrome. Some of them have autoimmune diseases, autoinflammatory diseases, Sjogren's syndrome. They can have extracellular matrix disorders such as the Ehlers-Danlos syndromes or others. They can have mood disorders. They can have some of these fatiguing syndromes. And so what happens is very rarely do any of these conditions happen in isolation. And the reason is that these are all neuroimmune access disorders that have particular phenotypes. And so some conditions have more of a fatiguing phenotype. And so that would be like your ME/CFS. Some have more behavioral, so like neuropsychiatric. But again, these are neuroimmune access disorders. Some have more extracellular matrix phenotypes, so more likely to have frequent subluxations or dislocations. Some have really profound immune dysregulation. But these are kind of all on a spectrum of these neuroimmune access disorders, and that's how we should be approaching them. So how do we make a diagnosis if it's this complex? Well, it's getting easier, but it's still quite difficult. The things that I like to use in my clinic are kind of like precision diagnostics, which very often include genetic testing. And I've actually been really surprised by some of the conditions that I've been able to diagnose based on genetic testing. The next thing that I think is really important is deep immune profiling. And I won't really touch on that today, but I am going to talk about tissue-based precision diagnostics, which also includes immune profiling. And then we have kind of like the standard things that we can use. So laboratory and stool studies. And again, the thing that I want to caution you on and kind of reassure you is that a lot of laboratory-based studies that are based on blood are going to be normal because for the vast majority of people, these are highly complex tissue-restricted processes. And so blood tests oftentimes are not good proxies for these types of conditions. We can also use different imaging modalities. We can use endoscopy. So this can be direct observation. We can sometimes see structural abnormalities. We can do biopsies, which include the traditional mucosal biopsies. And then I'll talk a little bit later about full thickness biopsies, which I think are going to be a lot more helpful for us. And then I'm going to talk about a new technology that uses confocal laser endomicroscopy to help us recognize gastrointestinal barrier dysfunction and tissue-restricted food allergies. There's a few other tests that I'll talk about as well to kind of get after kind of like motility type changes that can occur. But the point that I want to make with these is that they tell us that something's wrong, but not why it's wrong. And so the most useful tests tell us why something's wrong, because then that allows us to select a therapeutic more precisely. So this is actually one of my favorite tests that I have used that tells me something's wrong, but not why it's wrong. And so this is a wireless motility capsule, and you can see the capsule over here. And this is just swallowed by an individual, and they wear a recorder for up to 5 days. And what you can see is time on the x-axis. Over here is intraluminal pressure, and that's indicated by the height of these red lines here. And then you have pH in green, which helps us understand where the capsule is. The temperature is measured in blue, so this tells us when the capsule is ingested and when it is expelled from the body. And so this is a 24-year-old female with POTS, HEDS, excessive sleepiness, and cognitive impairment who's presenting with nausea, bloating, abdominal pain, and constipation. When I did this test, she had profound delayed gastric emptying. She had a normal small intestinal transit time and a normal colonic transit time. So really the focus is that something's happening in the stomach. And so is there something I can do about that? And so this is using a technology that allows us to in real time measure intraluminal pressure and dimension, right? And so it was originally designed to measure intraluminal pressure distension at the gastroesophageal junction, and that's what it's showing here. It's a balloon that's placed during endoscopy and then inflated, and then you get these readouts that tell us how much distensibility across this muscular sphincter there is. But so in this case of this patient, what we can do is we can actually use it to do the same type of measurement across the pylorus of the stomach and determine whether there is pyloric dysfunction. And if there is, there are certain things that we can do about that. But it helps us understand the pathophysiological mechanisms of where the delay in gastric emptying is actually coming from. This is another individual, another 24-year-old female with POTS, a disorder of energy metabolism, and a diagnosis of HEDS, who was presenting with nausea, bloating, actual abdominal distension, and abdominal pain exacerbated by eating. And again, she underwent this wireless motility capsule. And so what you can see is her gastric emptying time is just mildly prolonged, but not nearly enough to really account for her symptoms. But her small intestinal transit time is wildly pronounced. And so this is primarily where her symptoms are coming from. Her colonic transit time is normal. And so then this helps me understand what I have to do to improve her symptoms is I have to kind of target her small intestine. And so what can I do to try and understand when someone has these profound transit delays? Well, again, like I said, the traditional biopsies are not as helpful as a full thickness biopsy. So this allows us to get the mucin layer, the mucosa, the submucosal plexus, this inner circular layer of muscle, the myenteric plexus, the outer longitudinal muscle layer, and the serosa. And then what we can do is we can look at nerve fiber density, the ganglia, we can look at immune cell complements, throughout the entire wall of the gastrointestinal tract. And here's just an example. This wasn't using that technique. These are surgical specimens, but still it highlights the point. So in the controls, you can stain for the myenteric ganglia, and you can see here it's staining very robustly in brown. In the cases of individuals who had intestinal pseudoobstruction or intestinal failure, you can see that there's degeneration of the myenteric ganglia. The other thing, when they stain for immune cells, including mast cells, you see infiltration of mast cells into this area. The same was seen for lymphocytes and eosinophils as well. The problem is we don't know if this is cause or consequence. Are they there because there's an injury, or are they there because they caused the injury? But again, it's important information to know. What else we can do with these full thickness biopsies is really get a better assessment of what's happening at the tissue level. And so using technology where we're using multiplexed imaging on the same tissue sample, we can look at nerve fiber density, immune cell components, we can look at the extracellular matrix, and we can take multiple images and then make a three-dimensional rendering of them and really determine what's going on within the tissue. And so this is really precision tissue diagnostics, and this is going to help us understand these tissue-restricted neuroimmune disorders and allow us, again, to select better therapeutics for our patients. So then this is just another example. This is a 40-year-old woman. She had orthostatic intolerance, ME/CFS, and a diagnosis of HEDS, and she was presenting with nausea, early satiety, bloating, abdominal pain, and a sensation of incomplete evacuation with defecation. What's interesting is that she had a really delayed gastric emptying, so normal is about 4 to 4.5 hours. She's at 17 hours. Her small intestinal transit time was also delayed. Normal is less than 6, and she's at almost 9. And then her colonic transit time was actually within normal limits, but actually at the higher end of normal limits. And so this helps me understand that she has an impact on each segment of her gastrointestinal tract, and I'm going to have to think about that when I'm selecting therapeutics for her. Again, this is a 19-year-old female with POTS, HEDS, severe malnutrition, presenting with dysphagia, nausea, vomiting, and abdominal pain. And you can see that she has normal gastric emptying time, normal small bowel transit time, but really profound colonic delays. And so again, I'm going to have to think about this as I'm selecting therapeutics for her. And so what can I do now that I have this information? Again, it tells me something's wrong, but not why it's wrong. So now I'm going to briefly just talk about this way to test for food allergies that are restricted to the gastrointestinal tract. And so you can have kind of like negative IgE testing for traditional food allergies. The skin prick test in most of my patients is wildly abnormal. Usually they're pan positive, and that's because they have a more systemic mast cell disorder. And so then we can do endoscopy to make sure that there's no significant anatomical changes. And then we can do this test that leverages confocal laser endomicroscopy. And I'll just show you what this looks like. So these are the large villi within the gastrointestinal tract. And so this is a microscope. We're looking very up close at it. Kind of the individual dots are individual cells. And you can see they're highlighted within the villi because we've added fluorescein. But these dark spaces are the lumen of the gastrointestinal tract. So again, that outside environment. And if the barrier remains intact, the fluorescein should stay within the villi. So what we do is we go down and we look, and then if it's all normal, we add a food antigen and we wait and see what happens. And what you can see in real time is you have fluorescein leakage into the lumen. And so this person has had a massive systemic reaction to the food that was added intraluminally. And so they should avoid it. They have a food allergy. And so you can see this again. And so it's real-time diagnostics. And there's really great success if we remove these foods from a person's diet, that they will have durable improvement in overall gastrointestinal symptoms. This is very likely an IgE-mediated condition, probably involving mast cells. Blood tests are not going to be adequate. This takes the guesswork out of elimination diets, so really takes that burden off of patients to try and figure this out. And so we need to believe patients when they tell us they're experiencing the symptoms, and we need to perform better tests. I'm going to briefly, because I'm over time, talk about emerging therapies. I'm just going to talk about neuromodulation, immune system modulation, and immune system reprogramming just in the last 1 minute or so. This is the same technology that was developed for PTSD and anxiety and depression, called transcranial magnetic stimulation. You can use the same device and target the celiac, mesenteric, or pelvic ganglia of the gastrointestinal tract, and very likely improve motility, barrier function, those types of things. This is a really exciting emerging technology for improving the function of the gastrointestinal tract. Mast cell-directed therapies, there are some coming down the pipeline that are going to be much more effective than our antihistamines that we're using. Super excited about this Siglec-6 receptor agonist, because not only does it shut down kind of all the mast cell activity, it's also leading to antibody-dependent cellular phagocytosis, so kind of depleting that mast cell population, but without broad immunosuppression. And so this is going to be really exciting to see how this will improve gastrointestinal conditions that are mediated by mast cells. You can think about just how that would be applied to some of these food-related disorders that we're diagnosing using that confocal laser endomicroscopy technology, and other comorbid conditions that happen with autonomic dysregulation. I'm not going to go into detail, but there's a lot of excitement around JAK-STAT pathway modulation for neuroimmune conditions. There's a lot of drugs that are already on the market. We can use these, like in the United States, as repurposed drugs, because we already know the safety profiles and we can apply them to different conditions. Another drug that I'm really excited about is efgartigimod. So this is an FcRn inhibitor. So this essentially reduces circulating immunoglobulins. And so these are the drugs that we should be using for IgG-mediated autoimmune diseases, where the IgG molecule is causing pathogenesis, which is not the case in all conditions. Sometimes it's just a biomarker for disease. Other times it's causing real pathology in those conditions. This is what should be used. This should be first line well before any immunoglobulin supplementation therapy. In my mind, the only reason we would use immunoglobulin supplementation is if there are actual immunoglobulin deficiencies. And so this, I think, is going to show a lot of promise. This is already FDA approved in the United States for myasthenia gravis, and CIDP. It's in trials in Europe for Sjogren's and a whole bunch of other conditions. And so this is really, really an exciting advancement for treatment of autoimmune conditions. And then, if we can prove that autoimmune conditions are involved, we can start to use some of these CAR-directed therapies for immune reprogramming and ultimately cure. And so really, like in conclusion, I think that improving the diagnosis through discovering the actual mechanism of dysfunction helps us treat our patients better. It expands our therapeutic options and moves well beyond symptomatic management. And that's absolutely where we need to be. And so if I had to, because I'm always asked to put together kind of like, what do I do in the meantime while I'm trying to figure this out? I've included some of the drugs that I use. So first line for motility disorders, I will use pyridostigmine. This is an acetylcholinesterase inhibitor. Second line would be a 5-HT4 agonist. I tend to avoid the secretagogues because most of my patients have intravascular volume depletion anyway, and this can be counterproductive. But sometimes I have to use them, and then I'll use volume expansion, either using oral rehydration salts or IV fluids. If I have trouble with impaired gastric accommodation, I'm going to use clonidine or guanfacine. If I have elevated norepinephrine levels, I'm going to use clonidine or guanfacine. One of the things I didn't put on here is if I have really profound nausea, I'm going to be using NK1 receptor antagonists like fosaprepitant or aprepitant to treat those types of conditions. Also be using vision therapy and vestibular retraining because that can also be contributing. And then currently using immune modulators, but really hopefully to be getting into the space of immune reprogramming. This is my summary. So really the take home is the nervous, immune, and endocrine systems use a common language to interact with each other. And that's why we cannot think about these systems in isolation. This is really important. We see these conditions disproportionately and more severely impact females, and we have to use this to kind of help treat all of our patients, whether they're male or female. We know that the neuroimmune axis is playing a critical role in coordinating communication between various body systems to maintain homeostasis and respond to environmental cues. And when this goes wrong, a lot of things go wrong. We now know that many chronic illnesses are caused by dysfunction of the neuroimmune axis, and we need to leverage precision diagnostics and personalized therapies to treat these really complex disabling conditions. And breakthroughs in technologies to modulate the immune system and nervous systems are going to lead to new therapies that target the molecular and cellular mechanisms of these diseases. And they're not currently being developed for these diseases, but these diseases will be able to use them off-label. And I'm just going to conclude with some references. And thank you so much for your attention, and to the organizers for the invitation to be part of this fantastic weekend of learning. Thank you.